Alright, so this may be the start of the examination. If someone asks you to just carry on examining lying down, because the patient cannot sit up or they. Oh yeah, in the exam also, it's good to as you're approaching the patient, have a look and see if there's any walking aid. That will give you some clues. Okay. Otherwise, if you haven't inspected standing up, then you want to mention whatever we didn't talk about. Because just now when we did the inspection, we looked at the alignment, to see whether there's any deformities, any muscle wasting. So I can say this is a young gentleman who's lying comfortably in bed. Okay, then come to the end of the bed. And also for the spine examination, when spine you want to look for any wasting, it's best to come to the end of the bed. Because when you're on this side, it's more difficult to compare for symmetry. So if I come to the end of the bed, I can see if there's any obvious muscle wasting. Okay? And also here I can see if there's any obvious limb length discrepancy. Okay, so here you can say the attitude of the limb is normal, there's no muscle wasting, there's no obvious limb length discrepancy. Okay, don't be too distracted by, if the examiner asks you to specifically examine the hip, obviously if you see some deformity in the toes, you can mention it, but you don't have to label the point and start talking about the varicose veins or there's something which is not so normal. You have to be more focused towards it. So you don't have to say a lot of negative things, but if you see something obvious, then you mention it. Okay, then come back here. Okay, and now when you palpate, usually in other systems when you palpate, you want to start with the back of your hand to check for temperature. But in the hip is a very deep joint. You don't need to check for temperature. Okay, so we find the anterior spherical spine, and as a whole, when you do palpation, like even in the knee, don't palpate both at the same time. Okay, because then you don't know which side is causing tenderness. Okay, so say they ask you to examine the right hip. So you can start off with the so-called normal side. This is anterior spherical spine. This is the pubic tubercle. So where is the hip joint? Is actually directly in the center, okay, which is also the surface marking in the femoral artery. Okay, so you have the femoral artery, then you've got pectineus muscle, and then you have the hip joint. So this mid-inguinal point is the surface marking of the hip joint. Okay, so when you come to this side, you palpate the SIS, you find the pubic tubercle, see if there's any tenderness in the hip. Okay, and as a habit, even for the knee, you should know where your fingers are, okay, and you concentrate by looking at them. For example, here I want to find the joint line. I run my thumb down the femoral conda and I come to a step. If I don't find a step, then I suspect maybe you've got some sagging of the tibia. But this is how I locate the joint line. I come down here, they see there's a step, then I know the joint line is here. Okay, so with practice, you should know where your fingers are and what you're palpating. You concentrate and see whether they've got any tenderness. So for the hip, once I found the SI and the pubic tubercle, I know this is the hip joint, and I concentrate looking at him to see if there's any pain. So I palpate here and also palpate the trochanter. Okay, so that's the palpation done. Look, feel, and move. So move, when you think of move, immediately think first whether it's truly zero or not, because we don't know whether he's masking a fixed flexion. Okay, so again the same thing. If you have a fixed flexion, you cannot put your hip straight. You cannot go to neutral. Okay, then when you lie down, you will do that. Okay, you arch your back, so there will be a excessive lordosis. So here he's got some lordosis. When you put your hand down, you're not palpating the bed or the table. You're palpating the spine. Okay, you put your hand down here. Now if he's got exaggerated lordosis, well, immediately actually most patients when you put your hand there, they will do that. They say, no, just rest. Okay, just relax. So now I feel like this and I feel for his spine. And he has a normal lordosis. Okay, so it's not like it's completely flat. There's normal lordosis. Okay, so now if they ask you to examine the right hip, what you're going to do is you're going to use this femur as a lever to tilt the pelvis back this way. Okay, because now the pelvis is rotated this way in someone with a fixed flexion on this side. So once I come up to here, there's no more hip movement. If I push some more, it will rotate the pelvis. So I do this until there's no more, you can't see my finger, but you can feel my finger. I'm checking to see if there's any, that the exaggerated lordosis is obliterated. Once it's obliterated, then I look at this side, see whether this lifts off. If this lifts off, it's got a Thomas's test is positive. Now, if I do it excessively until the pelvis really rotates, of course you'll end up going up, because now you've really gone too much. So you just need to do it until there's no more exaggerated lordosis. So actually, if you put your hand down and there's no exaggerated lordosis, actually immediately is already negative. You cannot obliterate something which is not there. Okay, but just for showmanship, you just do like that, and then you feel, and then you look there to see if this lifts off or not. This lifts off, then Thomas's test positive. While I'm here, I will, instinctively, you see, I put my hand on the pelvis, because it helps me to know. You see, like now, you see the pelvis is rocking. Okay, that means there's no more hip movement. You're already moving the spine and the pelvis. So the hip movement is actually up to here. And if I push some more, I can get it looking as if there's more movement, but actually this is all the movement he has. Okay, obviously this is not normal, but because the trousers is tight. Okay, so the trousers limit. So see the pelvis is rocking already. So to check the hip movement, you come up until you feel, there's already some resistance, and the pelvis is starting to move. So this is it. So this is how many degrees? 90 degrees. Okay. So while it's 90 or so, I check for internal rotation and external rotation. So when you do this, the femur must be pointing straight up the sky. Cannot be doing that. So this is internal rotation. Okay, so the tibia is going outwards, but imagine what's happening at the hip. Okay, and you look at this angle from here to here. This angle. And how much is that? 30 degrees. Okay. Now in the knee it's quite easy, right? This is straight, 0. Okay? This is 90. Okay, but when you do like this, you must always see where the femur is, because this is 90. Okay, this is also 90. Just this angle. So 90 is something that you can see quite well. Now if you have something right in between, that is 45. Okay? And so if you have something between 0 and 45, if it's nearer 45, you call it 30 degrees. If it's nearer 0, you call it 50. Okay, so for example, if you have something like this, just decide, is it nearer 45 or nearer 0? 0. If it's nearer 0, you call it 15. If it's nearer 45 but not quite 45, you call it 30 degrees. So same here, this is 90, this is 135. Okay, if you have something more than 90, if it's nearer 90, it's 135. Okay, if it's nearer 135 but not quite 135, you call it 120. 120, yeah. Okay. So this is okay. This is how much? 60. Okay. Alright. Some people will say 60. Some people will say 45. Okay. So range of motion of the left hip is from internal rotation of 30 degrees to external rotation of 45. You don't have to say 0. You can just go from 1 to the other. Okay. Jump down. Okay. So now, when you move this hip, be a bit careful because it may be painful. Okay. So when you go up, just notice whether the hip goes straight up or there's obligatory movement. If you've got disease of the hip and the hip is no more like a ball, no more spherical, sometimes there is obligatory movement. As you come up, it doesn't go straight up, but it kind of twists because the head is already deformed. It cannot go straight up, it will start to twist. So when it comes up, sometimes it may like do that. It doesn't go straight up. Okay. So then say it comes up to here, okay, and then you feel that the pelvis is starting to move, then stop. Okay, there's no more. That's it. So 0 to
45.
60.
45.
Now, if the Thomas's test was negative or was positive just now, it's not 0. If you want to avoid any confusion, just say the flexion is 45 degrees. Okay, because it's not really 0, because it's now we found the Thomas's test positive. Now, you cannot go up to 90 degrees, then you have to look down the femur and look at rotation this way. Okay, but say it goes up to 90 degrees. Okay, and usually in hip problems, they lose the internal rotation first. Sometimes they have a fixed external rotation deformity. fixed external rotation deformity means that they cannot go, they cannot internally rotate to neutral. Okay, they can actually rotate more, but they cannot internally rotate to neutral. So that's a fixed external rotation of 15 degrees. Okay, otherwise you just say that on the right side, range of motion is from 15 degrees of external rotation to 45 degrees of external rotation. Okay, but you must stabilize this part. Yeah, you must stabilize this part, and you must look at the angle here. Okay. So what's left after flexion and rotation?
Extension, abduction.
Okay. Now, before you do abduction and adduction, you must do what?
Square the
What does square the pelvis mean?
to make the pelvic perpendicular to the trunk.
Yeah, okay, very good. So basically, if you palpate the anterior sphenoid spine, okay, a line which joins both anterior sphenoid spine must be perpendicular to the trunk. Again, this is because you want to find the 0 point. Okay, because for example, if he has a fixed adduction deformity, so again, it's the same word. Fixed adduction deformity means he cannot abduct to neutral. Okay, so here if I have a fixed adduction deformity, I cannot abduct to neutral. But I wouldn't stand up like this, or I wouldn't lie down like this. So what I will do is, I will do like this. See, the hip is still adducted. See my pelvis. But I won't stand like this, so I will stand like this. So, and that explains why if you have a fixed adduction deformity, you have a yeah, you have an apparent limb discrepancy. So an apparent limb discrepancy is due to a joint contracture. Okay, whereas a true limb discrepancy means one of the bone is short. Okay, so when I lie down like this. The hip is adducted. It's not constant neutral. So there's a apparent limb discrepancy. So when he lies down, okay, this pelvis, it's going to be like this. Okay. So that's why I have to square the pelvis first, because I do not know whether it's 0 or not. Okay. So what happens is, squaring the pelvis means that you must hold both lower limbs together. When you hold both lower limbs together, there cannot be any independent hip movement. So any movement that you do moves the pelvis, you see. So you do that until wherever the pelvis is perpendicular to the trunk, or is squared, then you just drop the lower limbs. And then you can see it. This side, the hip is adducted. Okay? So, tricky, because you're in the way a bit. Okay, you'll come to the end. Just come and see. Okay, so say for example it's like this. Okay, square. Okay, then I will do the so-called normal side first. I will check. Okay, like that. Okay, adduction is how many degrees? 15 degrees. Okay, and then, again, you see I'm putting my hand here. Instinctively, I'm putting my hand here because I want to make sure that I don't overdo it. It's not after I finish the hip movement, the pelvis starts to tilt, and if you carry on, it looks as if you've got a lot of range of motion. But you cannot. You must go up to there until you feel resistance. The pelvis is already moving. I drop. This is the amount of abduction. How many degrees?
15.
30.
And normally I just leave that there, okay, so that I can then examine the affected side. So the affected side, okay, adduct to there, but I find that they cannot go to neutral. Still got fixed adduction. Okay, so the range of motion on the right side, on the left side, is from 15 degrees of adduction to 30 degrees of abduction, whereas on the right is from 15 degrees to 30 degrees. Okay. Alright, you understand?
Yeah.
Okay. Alternatively, if you've got a fixed abduction deformity, then you're going to get an apparent limb length discrepancy, but the affected side appears longer. Okay, for the same reason, because got fixed abduction deformity, I can't go to neutral. So I have to do that. Okay. So when you square the pelvis, if I go over low limbs, I square the pelvis, I find that it's like that. Okay. So squaring the pelvis doesn't mean that you're putting the lower limb in alignment with the body. It's nothing to do with the lower limb. In fact, ignore the position of the lower limb. You are just looking at the pelvis. It just so happens you're using both femurs held together so that there's no more hip movement. So any movement you do will move the pelvis. Okay, because you cannot move the pelvis like that. So you just use the femur, the whole lower limb as a lever to get this square. Actually, there's no square. We just stop. It's the carpenter square, you know. Carpenter's got that square, so these two lines must be perpendicular to the trunk. Okay. So that's look, feel, move,
Special.
and special test. Special test is measurement. Okay, and after measurement, we do a neurovascular examination. So again, I do both together because it's quicker. And then ask them to pull upwards. Okay, pull up. Cock up both feet. Okay, just keep it that way. Cock up both feet. Okay, keep it like that. Don't move. Yeah. Because you have to be very specific with the patient. As soon as you put your hand there, he will think that you want to come down. So you ask them to move and maintain that position. Okay. As a good habit, ask them to do it before you put your hand there. Okay, because if they can't do it, then it's not even grade 3. Okay. For example, we are digressing a little bit. For example, I want to test the quadriceps. Okay, I ask them to straighten the knee first. Okay, luruskan lutut. Okay, simpan macam tu, jangan bagi saya bengkok. Okay, then you check. But if he say he cannot even lift up, there's no point to check whether it's grade 4 or not. Okay, sometimes in the stress of the exam, he didn't straighten up. You put your hand there and you say lawan, and you push, you feel some resistance. What resistance am I feeling? Huh? The resistance of the bed. Yes, the resistance of QU. Okay, you feel as if there's resistance. It's not because. Okay, so ask them to straighten up first. Okay, biar lurus. The grade 5. Okay, and for EHL, for example, later on you do in the spine. Okay, these two toes, pull it up towards you. Okay, pull up these two toes towards you. Okay, keep it like that. Don't let me push it down. Okay, now you come and compare both sides. Okay, and for example, if he has a slip disc and slip disc, most common slip disc is
L5S1.
Okay, either L4, L5 or L5S1. If you have L4, L5 slip disc, you get which nerve root affected?
L5.
L5, L5 nerve root. And this muscle I'm testing is? This muscle I'm testing is called this is longest, which is supplied by the L5 nerve root. Okay. So remember, you see, I can compare one side and the other side. Usually I put inside here, but I can't get. So that's why it's good to do both at the same time. But you see, if anybody, if I do this, okay, you must always test on the proximal phalanx. Never in the distal phalanx. The distal phalanx, then everybody will be weak. Okay. Okay. But for the hip examination, you just ask them to pull outwards. Just do upwards like this. Okay. See, they got a foot drop or not, and then you can keep it that way. Just push down, like you tekan brake like that. Okay. Keep it that way. Okay. Then you can check. That's it. Okay. Okay, we go back to the measure. So measure, there are two types of measurement. One is apparent
and true limb length.
Apparent limb length, the criteria is that the lower limb must be aligned to the body. Okay. So, for example, just now if for example he had a fixed adduction deformity, he would have just lie down. But then after you do the abduction, you square the pelvis. So after that, you just have to put the lower limb in alignment with the body, irrespective of what happens to the pelvis. Just put both lower limbs in alignment with the body. Now, if you had a fixed adduction deformity, the pelvis will end up like this. Okay, and then this side will be short. Okay, that's it. So for apparent, you go to try to avoid the umbilicus. The umbilicus is quite mobile, so go more with the distance. Okay. Of course, during inspection just now, you have some clue or some idea whether you're going to expect, or also the way that he walked, you have some idea whether it's got a limb length discrepancy. Now, apparent limb length discrepancy also you get a short limb gait. Okay. Okay, so you find the most prominent part of the medial malleus. The tip is covered by the deltoid ligament. You find that part which is most prominent, and you find the same spot on the other side. Okay, so from here, so you measure the normal side. You find this is the most prominent part here. There, and then
106.
this is the most prominent part here. Okay, if you get 0.5 like that, don't worry about it. Even up to 1, it'll be just measurement error. Okay, so then it, we're never 100 so exact, because it can depend on where you find that point. So like this now I got about 107 like that. Yeah, 106.5, so it's the same, no apparent discrepancy. Okay, for true limb length, you need to square the pelvis. Okay, so if, for example, the pelvis is square like that, okay, ignore this. This pelvis square already. So whatever position the lower limb is, that's the position you leave it in. The idea is just that you want to get this to be square. Okay, then you measure the normal side. Okay. Again, try and find the medial malleus and the most prominent part. Okay. Now, here I'm not doing it very well because I cannot. Luckily, it's quite thin, so I can feel the SIS through his trousers. Okay. Actually, it's not right. Because what's the other criteria for true limb length measurement? That's why it came out a bit shorter. So one is squaring the pelvis. The other thing is that both lower limbs must be in the same attitude when you measure. Okay, so for example, if say he got fixed flexion of the knee on this side, then when you measure, you must also mimic flexion on the opposite side. So here, this side is adducted after you square the pelvis. So to measure on the normal side, you also need to adduct. And then you measure. Okay, so both lower limbs must be in the same attitude. So the pelvis square, both lower limbs in the same attitude. Okay, but usually, probably by this time, the exam would have finished already. Or you wouldn't have come to this stage, unless they said, okay, do a Trenberg test, or just measure the lower limbs. They may ask you to do some specific part of the examination, because this is really too long, the bell will be out. Okay, but those are the... Okay, if there's no shortening, okay, so if I, very difficult because it's not proper bed, let's say, you keep it like that. So if I do this, okay, and I do this, there's no limb length discrepancy, that's it. Finish. If there is a limb length discrepancy, then you got to measure and see whether it's in the femur or in the tibia. If it's a long case, one quick way, running out of time, is to do the Galeazzi test. Make sure this is 90 degrees and it's not adducted. Okay, like this. And both heels are in the same level. Okay, you look this way, okay, and you see the length of the tibia. Okay, for the femur, you look this way. That book is a bit, the clinical examination book, one thing is a bit too flex. And also, they are looking this way, so that it's more the tibia than the femur. Okay, okay, but yeah, this one you're putting it like that, too flat. Let's say you put the 90 degrees, and here actually they're showing that the tibia is short. not so much the femur. Okay, so you can, but remember, if I adduct one side, also it will look short. So you must keep both neutral. Okay, and this heel must be both at the same level. Then you look from the top to look for femur, you look from here. Some people look from here, but usually I look from here. It's a quick way of checking how the guy is sign.
Brian triangle.
Okay. Squaring of the pelvis.
Is it in relation to the patient or must it be like, I don't know.
Yeah, in the book sometimes they talk about the bed, but obviously, if the trunk is lined to the bed, then you line it up to the bed. But squaring the pelvis just means that the line which joins the both ASIS is perpendicular to the trunk. It's nothing to do with the lower limb. It just so happens that using the lower limb to move the pelvis. So that's the definition, that this line is perpendicular to the trunk. Okay, in a normal person, when you lie down, it's really square. Okay, but in someone with a hip contracture, say a fixed adduction or fixed abduction, then he will lie down like this, but the pelvis is tilted in respect to the trunk. So before you start your abduction, you need to kind of zero it, or before you start your limb length measurement, you need to square the pelvis. So you use both lower limbs, because once you hold both lower limbs, you cannot have hip movement already, because you kind of locked it. Okay, so any movement you do will move the pelvis. So you're only using the lower limb to move the pelvis until a line which joins both anterior square-like spine is perpendicular to the trunk.
But what if before we do the movement for the square pelvic, the line already perpendicular, do we have to do the as relationship maybe?
Yeah, because you
Show.
You just need to show that you're trying to square the pelvis. So you just lift it up
Even though
and you do like that. Okay. But remember, because you have to just make sure. Okay? Doing the ASIS. In fact, some people, when they do abduction, I will put my hand on the opposite ASIS. Okay? So to detect any movement. Because when I'm doing abduction, the pelvis shouldn't be moving.
For the Brian triangle, is it necessary to measure?
Yeah, I mean, if you, like I told you, if you measured the whole thing and there's no limb discrepancy, then you don't have to measure it.
If above knee shortening,
If there's, okay, after you say this one is short, then you mark, you flex a little bit, you mark the joint line, okay, you measure. If this is short, or particularly your Galeazzi test is, Galeazzi sign is positive, then you drop a line down the ASIS like that, and you measure this vertical distance. Okay, that's a triangle. Okay, you're measuring the base triangle. You compare this one and this one. You also have some idea initially, because when you're palpating the ASIS and you're palpating the trochanter just now for tenderness, you have some idea. There's a discrepancy. But it's very uncommon for us, so I mean, you just need to know. Someone asks you what's the Brian's triangle, you just say, okay, I drop a line down from the anterior sphenic spine, and I'm measuring the vertical distance from that line to the trochanter. You just feel this, that. Okay, you can't really feel. Oh, yeah.
sorry
The tip, of course, is covered by the abductor muscles, but you try and find the most, as long as you find the same on both sides. So you know the basal trochanter is this shape. Laterally, so this one sticks up, you can feel like your own.
the most bony part.